Hi everyone, and welcome to the 2021 ANZ Melbourne Institute Health Sector Report webinar. My name is Richard Grayson. I'm the Head of Health for ANZ Commercial Bank and your host for today. At ANZ, we're extremely grateful to have the opportunity to again work with the Melbourne Institute at the University of Melbourne to produce this report. This is the fifth in a series. The others, which focused on GPs, specialists, the future of the medical workforce, and the impact of COVID-19 on the medical workforce, are all available on the ANZ Health website. For those of you who are not familiar with ANZ Health, we are a specialist business within ANZ and comprise of over 100 bankers across Australia. ANZ Health services everyone from the individual medico to some of Australia's largest healthcare providers. As banking specialists, we strive to be more than just a bank. We aim to have deep and insightful relationships with our clients, as well as be an active participant in industry dialogue. Hence, we're particularly excited to be involved today. Today's event is centred on the trends of the medical workforce after 20 years of expansion and asks what they can tell us about providing the best healthcare possible. Let me extend a warm welcome to each and every one of you. Let me also acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to the elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Before I introduce our speakers, let me just remind you of a few housekeeping matters for this event. This webinar is being recorded, and we will be taking questions and comments near the end of the session. To manage this, we're relying on the Q&A function found at the bottom of your screen. You can submit any questions at any time through this function. Shortly, I'll pass to Professor Anthony Scott, the lead author of this report, who will present to you for around 25 minutes. For those of you who are not familiar with Professor Scott, he leads the health program at the Melbourne Institute at the University of Melbourne. Following Anthony, firstly, we will ask Associate Professor Susan Wern, followed by Dr. Kim Jenkins, to comment and provide their insights. Each will speak for about 10 minutes, leaving us around 10 minutes at the end for Q&A. Susan is a Senior Medical Advisor in the Health Workforce Division of the Department of Health. She's a Clinical Associate at the Clinical Associate Professor at the Australian National University and works as a sessional GP in Canberra. Kim is the CPMC Chair. Previously trained in general practice, she's currently a consultant psychiatrist working in private practice. I'm sure you'll agree that we're exceptionally lucky to have such a highly regarded presenters with us today, and I'm certainly looking forward to what they have to say. On that note, I'll hand across to Anthony. Thank you.
Thank you, Richard, and hello everyone. Let me just share my screen. Okay, hope you can all see that. Well, yeah, so welcome everybody, and thanks again for coming along. I'd just like to first of all just thank ANZ for their support in producing this series of reports. It's been a great way just to get an overview of the sector and what's been happening over time. I'd also like to thank Richard in particular, and also Glenn Fisher, who've been working closely with to produce this report, and then also staff within the Melbourne Institute who have helped produce the PDF version of the report, which will be circulated after this meeting. So I guess there's a lot been happening in the past year that we're all aware of. One of the things is that with COVID-19, it's really shown how flexible the medical workforce needs to be and can be when push comes to shove. But that also raises issues about how flexible it needs to be in normal times without a pandemic, and that's a continuing issue. We've had around 20 years of medical workforce expansion now, with doubling of the number of medical school graduates and number of medical schools. And yet, it's kind of been a slow burn in some ways, because that supply takes a long time to come through. And at the moment, there's still evidence and concern of a mismatch between supply, in terms of where doctors are geographically, which specialties are in, and community need. And we're also about to see in the next few weeks, I think, Susan will tell us, a new national medical workforce strategy, which is going to hopefully help address some of these issues. So what I want to do today is really to examine some of the key trends in the medical workforce. I want to examine its growth, its distribution, look at specialty choice, look at issues concerned with earnings, and also finally look at telehealth. So in terms of growth, we can see that in 2019, the number of doctors in clinical practice exceeded 100,000 for the first time. And the growth that you see here has been fueled by the medical graduate expansion growth. We can also see that, the number of junior doctors, the bottom purple line, has been growing by 5.5% a year since 2013. The number of GPs, 3.5% per year. The number of non-GP specialists, 4.5%. So there's been significant growth across all types of doctor, some more than others. But we need to set that against population growth, which has been 1.6%. So numbers of doctors are now growing much faster than the population. And in particular, the number of GPs is growing much more slowly than the number of non-GP specialists. And this is particularly interesting in a time of a growing burden of chronic disease, where you think more generalist type of doctors would be more needed. And so there is this is interesting in a general accepted need for more generalism, at least in the aggregate. That doesn't seem to be happening yet. So one of the things that we've also found is that, 20 years ago, the idea was to flood the market with doctors. If we flood the market with doctors, they'll eventually kind of peter into rural areas when they can't get any jobs in the cities. And we're kind of beginning to see that. Now, if you think of all these doctors in training coming through, the capacity of hospitals in cities to kind of train these doctors is pretty limited. And so on the left, we can see that there's much more, there's a larger growth in specialists in training outside of major cities and inside of major cities. Okay, so we're seeing faster growth of doctors outside of major cities generally, and for hospital non-specialists as well as non-GP specialists. So, doctors outside of cities are increasing faster than those inside of cities. There's been policies to kind of support doctors within cities in terms of training locations outside of cities and training doctors in private hospitals as well. So there's been a conscious effort to shift the training away from cities, which we can see in this data. And that's interesting. I mean, the interesting thing is non-GP specialists, which is the second set of bars there. Is that then, and these are qualified specialists, is this a result of oversupply in cities and doctors spilling out into rural areas, I guess? And there might be a number of different reasons for that. Now, also in this chart, we see that the growth in GPs outside of cities has been slower than the growth inside of cities. And obviously the number of GPs is growing in both, but it's faster inside of cities. And this is, a lot of the workforce distribution policies have been focused on GPs, lots of incentives and a lot of effort put into changing training pathways. Now, some of those policies are fairly recent and so haven't yet, I guess, had their effect. But nevertheless, it is concerning that that the number of GPs is growing more slowly outside of cities and inside of cities, and that's something of concern. And all this data, by the way, is from the Department of Health's Health Workforce Planning tool. Now, another thing that we want to talk about is the self-sufficiency. I'm sorry if you can hear a dog barking in the background. I'm at home. Anyway, I'll keep going. Now, self-sufficiency was a stated policy objective. And again, we can see in this chart that the numbers of international medical graduates have continued to increase, again, faster in some sense than the domestic growth in the number of doctors. And that, again, is a bit of a worry. The self-sufficiency means that we expand domestic supply, but also then want to, cap in IMGs in order to create space for these domestic doctors to have jobs and to move into rural areas. There was some changes in 2018 to temporary resident visas, and other policy changes suggested, but I'm not sure that they have really had much of an impact yet, and we can't really see this in this data. COVID-19 might have partly accelerated the policy of self-sufficiency because obviously we've had travel bans and the borders have been closed. Visas are still being awarded, but it's hard for new immigrants to kind of come to Australia right now. So, that might have created some space for these domestic graduates to get jobs, but also might have created some more short-term issues in filling vacancies in rural areas where we can't get anybody from overseas right now because of COVID. Interesting to see if that's actually the case. But in the last half of 2020, doctors were put back on the kind of priority migration skilled occupation list. So, we're not really being able to control IMGs very well or reduce their number, I don't think. Remember, a lot of IMGs are brought in by employers, by GP practices, by hospitals who see it as a more flexible way of staffing when they can't get any domestic graduates there. So that's cost effective for them, and it's largely demand driven. So I think generally, IMGs are set to remain a key part of the medical workforce, especially the rural medical workforce, for some time to come, and that is important to recognise, and therefore is self-sufficiency really a goal that we should still be pursuing after 20 years of growth when we haven't really been able to put a dent into IMGs coming into the country. The next thing I want to talk about is the fact that we have not enough GPs and perhaps too many specialists, and what things are driving this. Right now, there are an issue with filling GP training places. That's becoming more difficult. Applications are falling for GP training places. And over the last 20 years, there's been really no explicit policies to really address this distribution between GPs on the one hand and specialists, non-GP specialists on the other hand. There are, of course, a range of factors influencing specialty choice, and this is taken from a review we did a few years ago for New South Wales Health Department. But a lot of these factors are just how they are. Some are more modifiable than others by policy. We know in terms of people's characteristics that medical schools are encouraged to recruit those from a rural background, and that might, you might end getting more doctors into rural areas that way. In terms of characteristics of education and training, it's what supervisors and the nature of training and supervision that really drive people's specialty choices as well. People listen a lot to their peers around them, and obviously those peers are biased in many ways with their own experiences. But we also, that there's been we know that those with high levels of educational debt as well will also choose, more remunerative specialties that compared to general practice. But there's been very little in terms of, the structure and regulation of training, number of distribution of training places to kind of influence people's choices. And then also the job characteristics of the specialties themselves, which include earnings, on-call, hours worked, opportunities for self-employment and that kind of stuff. So there's a lot of factors in here, and we know a little bit about them, but not very much after 20 years. For this chart, I just want to focus firstly just on the top line and the bottom line. These are the earnings of GPs in the bottom line and non-GP specialists in the top line over time. I'll talk about the other blue lines in later slides, but just focus on the dark blue lines at the moment. We can see here that if earnings matter to doctors when choosing a specialty, that things aren't getting better. First of all, the growth in earnings, and this is data taken from the Mabel survey, where we ask doctors about all of their income that they have from working as a doctor after practice costs, but before tax. So this is a kind of the gross take-home pay, if you like, that we're looking at, self-reported. But we can see that certainly the incomes of non-GP specialists have been growing twice as fast as GPs, and they're also almost twice as high as GPs. And that gap has been slowly increasing over time. The Medicare fee freeze won't have helped. That was disproportionately affected GPs because they were more likely to bulk bill, more likely to be affected. So that certainly hasn't helped this gap. And to the extent that income is important for doctors when choosing a specialty, this isn't really helping. We did do some work with Mabel earlier on where we gave doctors some choices about different specialties with different characteristics, and we're able to simulate what would happen if you changed a few things. So let's say we increased earnings of GPs by 50 grand. That's going to increase the probability of choosing general practice by about 10 percentage points. If we increase the amount of procedural work that they do from none to some, then that's also going to increase the probability of choosing general practice by about 13 percentage points. And again, academic opportunities has a slightly lower impact. So, earnings isn't the only thing, but other policies could also have an effect on the probability that the doctors will choose will choose general practice training as a specialty. So back to this chart again, and there's a few things here. I want to first of all just point out the middle two blue lines. So these is fee revenue of doctors, and this is taken for 2,000 of our Mabel survey respondents. We got permission from them to link their data to Medicare data, and so this is their total fee revenue from Medicare per doctor over time. You can see that this is falling for non-GP specialists at the top and GPs at the bottom. I'll talk about the relationship between these lines in a moment, but focusing on those two blue lines, the two light blue lines in the middle, we can see that this is falling, and there might be a few reasons for that. I think one reason that, and be interested to hear people's comments on this, but I think one reason is this increased supply. So we know that the number of doctors are increasing faster than the population, so there are fewer patients to go around, and that's one explanation for this falling fee revenue over time. And we know that the number of patients per doctor is falling, and the number of services that doctors provide per doctor is falling. We might think that the number of services per patient is increasing, and it is by about 1.8%, but the number of doctors is still increasing faster than that. So I think, we can explain this partly by supply increasing faster than demand, and this is causing a pressure on fee revenues. There could be other explanations within that as well. But why are these lines different? We've got Mabel data showing that earnings are increasing slightly, and the Medicare data showing that fee revenue is falling. And there are a couple of explanations for that. So first, if we look at the bottom two lines, which focus on GPs, we expect fee revenue to be higher than take-home pay, if you like, because in the middle is practice costs. And so that's an issue. This dotted blue line for GP should probably be a little bit high, so it shouldn't really cross at that end, because Medicare fee revenue isn't total doctors' revenue. Doctors get revenue from the Practice Incentive Program, which may not be included in that. They get revenue from pathology companies renting a room in their practice. That's not included in this either. So, you know, that line is probably going to be a little bit higher. But it's telling us as well that doctors, in the face of falling fee revenue, GPs have managed to maintain an increase of earnings slightly, and that can be because they are either reducing practice costs or they are getting income from other sources. And for those, that's kind of speculation. There's no data on practice costs over time, nationally or otherwise, that I've come across. So we don't know really what's happening to practice costs over time. But that's one issue. For non-GP specialists, there's a bigger gap at the top. So we're just comparing the top two lines now. We know that the top line includes specialists in the public as well as private sector. So that gap reflects public sector income from public hospitals, whereas the solid blue, light blue line is just their private practice income, if you like, from Medicare. So that gap is expected because the top line includes income from the public sector as well as private. But that gap is again increasing over time, and again suggests that our doctors, our specialists, spending a bit more time in the public sector perhaps than in the private sector. And we've got some other evidence from that. Since 2015, we know that there's been a drop in private health insurance coverage, a fall in the growth in the demand for private healthcare, and some evidence that doctors have been shifting their time back into the public sector. So that's one explanation for that. And also, one slight elephant in the room is that there's anecdotal evidence, but again, I haven't seen any data on it, that specialist private practices are becoming more corporatized as well and larger. And that may be a reason why their practice costs might be falling over time as well. So that's interesting. It also links back to the previous slides on non-GP specialists, where the growth is higher outside of cities. If, as we see here, that these specialists are spending more time in the public sector rather than the private sector, that reduces job opportunities for new qualified registrars who may be, kind of pushed out into the suburbs rather than into the cities. So that could be having an effect there as well. So there's lots of moving parts here, but it's important to consider these broad trends if we're to understand really the kind of changes in the medical workforce that we're observing. Now, in the face of falling fee revenue and kind of flatter earnings, doctors in private practice particularly, they have to think about the balance between their billing and how many patients they see. We can see the bulk billing has been rising over time, over this 10-year period, for all types of doctor. But the proportionate increase is much higher for non-GP specialists. Although non-GP specialists in 2019-20 bulk billed just 36% of their services compared to 87% of GPs, they've experienced a much larger percentage increase in the rate of bulk billing than GPs. So there's stuff going on there where the non-GP specialists are bulk billing more patients. And that is of general interest, because if you bulk bill more patients, you get less revenue, but then you can compensate for that by increasing the fees you charge for non-bulk billed patients. So this is what this is showing. Again, this is taken from aggregate Medicare data, CPI adjusted. And this is the fees for non-bulk billed services over and above the rebate. And those have been rising. Again, those have been rising faster for GPs. Again, they were more affected by the fee freeze as well. But it's also been rising for non-GP specialists. And certainly this balance between maintaining the number of patients seen and what they are charged might be becoming a bit more difficult. We know that doctors charge richer patients more, and therefore, increasing the fees for non-bulk billed services, richer people can absorb that. They're not going to change their demand. They're not going to visit less. I've heard some specialists say that I increase my price and more patients come. But also for GPs and for those patients on lower incomes, doctors are more likely to bulk bill as well. So we can see that dynamic has been changing over time, and how much that will continue to change is to be determined. Telehealth. Now, I guess with telehealth, there's been high hopes for telehealth since COVID started with all the new items coming in, and that's something that everybody's been watching very carefully. Again, this is the latest Medicare data up to March this year, which shows that about a year ago there was a clear substitution between face-to-face consultations and telehealth consultations. This data is for GPs. The data for non-GP specialists is very similar, but since then, telehealth has been falling over time, and you would expect that given COVID, although this past couple of weeks it might have increased a bit in Melbourne. But one thing from that is also that it's been merely telephone consultations that have been happening. There's been very low use of video. This shows the percentage of total attendances using video. We can see the bottom line for GPs that's been the lowest. So it's less than 1% and falling. The top line is for non-GP specialists in private practice. This is Medicare data, recall. So they've had a much higher use of video compared to GPs. But that's continuing to fall, but it's still about double the amount for GPs. What we don't show or haven't got any national data for is the use of telehealth in public hospitals and public outpatients. And we don't know really what's been happening there. The middle line there is these old telehealth items, which were claimed by non-GP specialists largely to see patients in rural areas. And there was an increase in these old items, and that increase seems to have remained. It's fallen a bit, but seems to be a permanent shift in the use of those video consultations for those kind of attendances. So that's interesting as well. Some of the research that we've done based on our Melbourne COVID survey last year and other work is that we know that factors that reduce the use of video include infrastructure. So doctors who've used video before, more likely to use it now. Excuse me. Doctors with more elderly populations are less likely to use video. And again, that's something that is related to kind of patients being able to use video, which is important. And then also, I guess, the funding for telehealth has been extended to December this year, but that's still uncertainty about the future of this funding. So maybe, practices haven't seen the need to invest in that infrastructure just yet until more permanent funding is announced. Another thing, which again is related to some current suggested reforms of this, is that we see that the proportion of level A, B, and C and D consultations, where level A is the short consultations, level B is your standard 15-minute, and C and D are longer consultations. The proportion of level A's using telehealth has increased substantially and stayed quite high. About half of all level A consultations use telehealth, excuse me. And that's really interesting because these are for shorter consultations, might be for repeat prescription to get test results. GPs may have been doing this before, phoning people up with test results but not getting paid for it. But there seems to be a clear need for these kind of short consultations. There's nothing worse from a patient's perspective of the GP telling you need to come in to discuss test results make a trip to the doctors, a couple of hours out of your day, perhaps, when they could easily call you up. So there's lots of increased convenience for patients for this as well. And there's some suggestion that the rebates for these different types of consultations may be changed in the future. And also, of course, there's little the rebates for video and telephone consultations are the same at the moment. So I think there's a strong need to kind of change them in order to increase the use of video versus telephone for those consultations which are appropriate to do so. Okay, so just to conclude, I guess after 20 years of an increase in supply, the challenge has always been how best to use these extra doctors to better meet community needs. And we're still struggling with that after 20 years. 20 years seems a long time, but it's been a slow burn given the length of time it takes to train a doctor. And certainly the decisions that we make now aren't going to see the effects of that for another 10 years' time. But nevertheless, it's an important that this is steered in the right direction. We found some evidence that growth outside of cities in the number of doctors is now faster than the growth of doctors inside of cities, and that's generally good. There's a number of reasons for that in terms of why doctors might be, particularly non-GP specialists, spilling over into rural areas now. Our city's full, but for GPs, it's still worrying in the fact that we haven't really seen faster growth outside compared to inside of cities. This competition is also increasing pressure on fee revenues, and we're seeing also changes to billing patterns, which kind of reflect that pressure to kind of maintain volume while maintaining income, if you like. One thing is, although there have been national policies to kind of look at some new training pathways into rural practice, and there's generally been no specific policies about changing specialty choice to encourage more GPs versus more non-GP specialists. So that's an issue that's still important, particularly given the changing epidemiology and disease patterns. Self-sufficiency question mark, is this still a thing that we should be pursuing? It's very difficult to reduce immigration. Immigration is flexible and useful for employers when they can't get domestic doctors. And, when you hear of junior doctors already thinking of alternative medical careers, alternative careers to medicine, because they feel that they might not get a job in a city, then, self-sufficiency needs to be reconsidered, I think. And I think with COVID-19 still upon us and certainly not, not resolved and won't be resolved for a while, I haven't seen really any more evidence on the appropriate use of telehealth. Again, we've had it for more than a year now. Are trials being funded about this or more studies being undertaken? I haven't seen this. So it's interesting to see what's going to happen with policy changes if they actually haven't been informed by evidence about what works and what doesn't. And generally, flexibility and adaptation is a key theme going forward for the medical workforce, for the way doctors are trained and how flexible they can be to changing needs and demand. So I'm going to stop there. Thank you, everybody. I'm going to now hand over to Susan. So I'll stop sharing my slides. Thanks, Susan. Is that okay?
Thank you, Tony, for a very eloquent summary of the stats that have been going around in my head for the last few years as I've been involved in working in health workforce in the Department of Health. So I'm going to start just with a few reflections on what you've said and then talk through what we're planning in the National Medical Workforce Strategy that you referred to, and also wanted to just share with the group some plans that we're thinking about in terms of non-GP specialist distribution. And I'd like to acknowledge that I'm coming to you this morning from Ngunnawal country in a rather wet and soggy Canberra, but at least I'm allowed to go out and get wet, which is a privilege compared to many Victorians who I realise are coming to us from lockdown. So thank you, Tony, for you and your team for collating the report, and the issue around workforce growth and the fact that we now have way more medical graduates than we used to is really what's giving government the impetus to think about a national workforce strategy. Previously, when we didn't have enough doctors, it was much more difficult to think about, well, how can we do, what can we do in education and training to make sure that we end up with people in the right place? But now we really do have that opportunity. It is heartening to see some of this, what you referred to as the spillover of non-GP specialists moving into more rural areas. But as you say, distribution of general practitioners and the distribution of people choosing general practice remains a problem. And as you say, we've spent 20 years we've been increasing the number of GP training volume in rural areas, and I've been part of those programs. And yet we're still not seeing people choosing to stay in rural areas once qualified. The issue regarding self-sufficiency and international medical graduates always is a bit personal for me, having come in as an international medical graduate and worked in Alice Springs for many years, very happily and well supported. But we are now producing enough in Australia and enough doctors, and it's interesting that this seminar is being sponsored by ANZ. It is a national investment that is made in training the medical workforce, and as part of that national investment, it should be recouped in some sort of reasonably equitable way, so that the person who's paying their taxes on a remote cattle station gets access to basic services just as much as the person who's paying their taxes in a city area. So we are aiming to go for self-sufficiency. And I think there's the difference between seeing IMGs as an employer flexible and easy workforce compared in the short term, compared with what we can see in the data regarding long term. So the long term is that people will move to the cities and will move to the more lucrative jobs. So it's IMGs are a band-aid rather than a solution in terms of workforce planning. I think in Australia is always going to be a country where people want to move to, and we don't want to be totally cut off from anyone coming in from overseas with particular expertise and a different approach. We are, apart from the Indigenous people, a nation who've tended to migrate here. So that's not going to change, but we must change the way that we rely on IMGs. And there's some interesting work during COVID around when people couldn't rely on IMGs, actually looking at what they called their workforce hygiene and treating junior doctors in a different way such that they stayed on in their jobs rather than using the IMGs as a cheap way of not looking at those workforce issues. So moving on to now, how is government trying to respond to the problems that you've identified, Tony? I'm going to start sharing my screen. So the National Medical Workforce Strategy is a collaborative piece of work between all the major medical stakeholders, plus all the and states and territories, AMA, rural doctors, It has to be, because there are so many different organisations who have an impact on medical workforce. None of us can change the issues that Tony's highlighted in isolation. So the areas we're hoping to work on is, there's three themes that go across the whole strategy of the importance of the Aboriginal and Torres Strait Islander workforce and improving cultural safety for all the workforce, adapting to and using new models of care, and improving doctor wellbeing. And the priority areas that we're wanting to look at, the first one is better data. I mean, we've seen from the presentation how good data really begins to tell a story. But much of the data that we have within the Commonwealth is MBS and pharmaceutical benefit scheme data. We don't have as much detail about hospital activity. We need to include the work that is done by NGOs as well. So we're trying, the first thing we want to do is to get a really good data tool that encompasses all the information about workforce. Then the next plan is to try and rebalance the supply and distribution, of making sure that we do have the number of training spots that we need to for different specialties, and that it's clear to junior doctors which specialties there's going to be work in and they're going to have a well-supported career in, and which they're going to be, as Tony said, maybe fighting for patients. That's not a good investment for them, and it's not a good investment for society to train them in a discipline that's not needed. Next one is making sure that we change the training pathways, very much a focus on more rural training. And it is encouraging to see that non-GP specialists shift to more rural, but we'd like to increase that much, much more. Fourth is building the generalist capability of the workforce, as was mentioned, the general practice workforce, but also making sure that those who enter non-GP specialisms don't focus just on their subspecialty, but are able to look at the whole part of their specialty, and in particular be skilled to go and work in a rural area where, as the cardiologist, they will be doing electrophysiology and all aspects of cardiology, not just one part, and also hopefully contributing to the on-call roster in general medicine. And the final bit is building a flexible and responsive medical workforce, trying to make sure we don't lose people's skills, either through the fact that they haven't, trying to make training a more modular approach, so that what you do shows and is giving you credit, even if you don't then get to major specialty qualification. So that's the main areas of the workforce strategy. We are hoping to get this endorsed by the Medical Workforce Reform Advisory Committee, which is the big committee who's been working on this for many months, with a steering committee underneath that group. We will then need to go to ministers for their endorsement, as will all the states and territories. Finance are interested to know whether the workforce strategy is going to cost money or save money. Absolutely, if we get this right, it will in the long term save money, as we're putting our investment into the careers and locations where we need doctors to work. Lastly, I just mentioned about changes we're thinking about with districts of workforce shortage. So these are the areas where you can come and work and get a provider number if you've come in from overseas. Up till now, we've only limited that for 8 different specialties, and we're planning to change that most medical specialties would be expected to be working outside a metropolitan area. So that's quite a big shift in our policies, but is intended, if that goes ahead, and I say it's just under discussion and happy to have comments back from people, that's under discussion at the moment, but should, we hope, increase not just the spillover from urban, but a deliberate relocation and working where needed for those specialists who come in from overseas. So thank you. My time to now pass on to Dr. Kim Jenkins, who has been a stalwart on the steering committee of the workforce strategy and is going to share her thoughts now.
Oh, thank you, Susan, and thank you, Tony. I'm coming to you from Wurundjeri lands, and so I pay my respects to elders past, present and emerging. I think, once again, Tony, congratulations on the research and the report that you've presented. And what I was going to talk about today was really just having read the report and then sort of gone away and reflected on it, and just share some of my reflections on that report. And they're largely qualitative, and I'm watching the time to make sure we've got some time for discussion and answering the questions that are coming up in the Q&A. But I think one of the first things that struck me about the rural and regional issues that you present is that we can't rely on market forces to cause the spillover. There's a little bit of spillover happening into rural areas, but it's not enough. And okay, some of increased financial incentives to get more people working regionally, rurally and remotely are going to help. But that's not going to be enough either, because people are concerned about their lifestyle opportunities for their partner, for their children, for schooling, and other aspects of their lives. So I think that while we can work really hard to try and get our medical professionals out into the regions, it's not really until, and this is my thoughts, I don't have evidence for this, but it's a reflection on it, we're not going to really see it happen until the general population moves more regionally and rurally. We're beginning to see that with the effect of COVID and more people working regionally, that the regional and rural lifestyle is becoming more attractive. And therefore that the medical profession may follow when the general population follow. But I think there's many factors that are outside the actual work that you do that affect whether people want to work regionally and rurally. And this one, it presents a little bit of a paradox here because of the figures that you've got in the study about GPs, because one of the things you presented was that, you know, making general practice more procedural and gives people greater job satisfaction in general practice, as well as paying people more. But if you're working out of the big cities, you're more likely to have a procedural general practice and be involved in that more, that sort of area of work that you've identified as being more sort of valued and more likely to want people to move. So there's a bit of a sort of paradox there, that the type of work that you can do rurally and regionally is what makes it more interesting, or people would say it was an incentive, but it's still not enough. And the relative earnings is crucial here. And, you know, the gaps between GPs earnings and the earnings of non-specialist GPs is, I think it's horrendous. You know, as somebody who used to be a GP, it's really hard and really, really challenging to be a good GP and do a good job. I you know, personal experience is it's actually a lot easier to be a specialist because you know what's going to come through the door, and you're more likely to be working in a very sort of contained, structured environment and have less of the additional stressors of running the practice and managing that come with general practice. And I think other things that make being, you know, that are sometimes lacking in general practice are opportunities to get involved in other aspects of the medical professional work, is like opportunities for research or really working as part of a multidisciplinary team. So I think it's those increasing those professionally enriching activities and opportunities for GPs can actually make going into general practice more attractive. If we think about IMGs, like Susan, I'm an international medical graduate. I came here many years ago now. And I came at a time where Australia didn't want IMGs. And I only got into Australia because I was married to my husband. How times have changed. But the cost of employing a full-time international medical graduate in a health service is a lot less than employing a locally trained doctor, even for sessions. And I think that is a very strong factor in IMGs being in more regional centres. And I think it's probably one of the factors that makes people who've come from overseas, once they don't have to be in that area and they've worked that hard for a lower income than locally trained colleagues have got, wanting to get out and move back to the big cities. And the effects of COVID on the numbers of international medical graduates through the last year or so, and the people being able to come into the country has been huge on issues of service delivery in some areas. And I think particularly in regional areas, and particularly in states like WA, which have relied so heavily on the international medical graduates to adequately staff their services. And the closures of borders, particularly thinking about border closures at the moment with being in Melbourne and borders being closed to people from Victoria, have made us locals less available to go and fill up those locum positions. So impacts of COVID there, very important on workforce. And if I just have a few comments on the telehealth data, it's not surprising it's falling after an initial surge. To begin with, when the telehealth item numbers came in, we had no choice. It was the only way we could deliver healthcare. And then as time's gone on and we've been able to go back to face-to-face consultations, it's what people want, it's what people need. We need human contact. And telehealth is valuable, it's incredibly valuable, but it's not without its limitations. And I'm a psychiatrist, I work in an area where we've long used video health. And psychiatrists, more than GPs, use video. And for me at the moment, using video health is preferable to doing face-to-face, because if I'm doing face-to-face with masks on, I can't read the person's expressions or read their body language so well, but it's easier to do that on a screen where people are not got masks on. But my consultations are long consultations, and if there are difficulties setting up the video connection to begin with, it's not so crucial if I lose 2 or 3 minutes of a 50-minute consultation. But if I've only got a 15-minute consultation, losing those few minutes worrying about connections is valuable time that I could have spent talking with the patient and addressing their issues. So again, it's not a surprise that telephone has been and consultations have been preferred in general practice. But it's also been a bit hard because some of the billing systems around the telehealth numbers have been a bit clunky and difficult to use. But I think the telehealth and video health are here to stay. And we made huge sort of gains in getting on board with that very rapidly. But going forward, we're going to need a much more nuanced system and things. So, and I think one of the crucial points that's already been made and is definitely highlighted in your report is patients' access to video and specific video health with specific populations and things, and the difficulty in that, and the fear that there are certain demographics of our population. We talk about older people, but there are people who don't have access to specific video health. And, you know, reflecting on your talk and Susan's talk, those challenges of how to get doctors to where we need them in doing a role where the community needs them to be, doing a role that the community needs in a way that the community needs them to do it, is an eternal challenge. And I really look forward to the outcomes of the medical workforce strategy in trying to address that. And if we talk about self-sufficiency of doctors, it takes a long time to grow a doctor. It takes even longer time to produce a GP and a non-GP specialist. So there is always going to be a time lag. So and the goalposts and moving, or sands are shifting, whatever metaphor we want to use. So it's, you know, it's not crystal ball gazing. But it's really hard to predict what medicine will require of its professionals as we move forward. And there's a lot of anticipation in what the medical workforce needs. So a huge task, and one that got significantly harder because of COVID, but a task that we can't afford to neglect. And I might just finish up by mentioning a body of work we're doing through the Council of the Presidents of the Medical Colleges, and that's a study to look at the effects COVID has had on training and education, and we're going to across the board, and delay in workforce, and we're hoping that the recommendations coming in that are going to help inform the National Medical Workforce Strategy. So thank you. I'm sorry I haven't left time for questions.
All right. Hello again, everyone. And sorry, we have run almost right up against time there. What we might look to do, there's a couple of really, really interesting questions. I think if I just summarize, the themes are a lot of interest around the data on GP fee revenue, how we split out the GP subcontractor versus the business. And there's also some really interesting questions around how junior doctors might adapt to what the future workforce looks like, as well as some themes around that, you know, how do we manage the GPs into regional locations? You know, is it a push, is it a pull? So there's definitely interest in those three points. What we might look to do is try and respond in a separate way, whether it's via email or through Q&A or through our email response on each of those. So unfortunately, we do have to finish up there. So on behalf of ANZ Health and the Melbourne Institute, I'd like to thank you all for your attendance. I certainly hope you've enjoyed the event. We will, as I say, provide access to the report itself through the chat function and find a way to come back to you on some of those questions. Of course, if you're in the health industry and are interested in having any further discussions around industry trends or anything like that, please feel free to contact me. My email address is richard.grayson@anz.com. My phone number is 0401 693 718. And before we do conclude, a special thank you to those who have worked tirelessly to make this event possible. In particular, Glenn Fisher, thank you, Glenn, and Jess DeLon at the University of Melbourne. Once again, thank you to our panelists. Thank you for joining us, and we'll see you all again very soon.